Welcome back to the Healthy Chicago podcast, where local health professionals and their guests discuss the latest public health issues affecting Chicagoans.
Welcome to the Healthy Chicago podcast. This is the Chicago Department of Public Health's podcast for making information available to you, to the Chicago public, about how to promote your health and wellness. I'm Matt Richards. I'm the Deputy Commissioner of Behavioral Health at the Health Department. I'm really pleased to have two guests that are friends, colleagues, that I want to welcome to the show today. We're going to be talking about mental health in Chicago, in the county, in the state of Illinois. So welcome. I'm with Dr. Tom Nutter, the Chief Behavioral Health Officer for Cook County, and with Chief David Jones, the Chief Behavioral Health Officer for the state of Illinois. We work closely together, representing city, county, and state. And I hoped you could just first introduce yourself a little bit, talk about your role, Dr. Nutter, at the county, how long you've been in the role, what you're working on right now, and then I'm going to ask you the same thing, Chief.
Sounds good. So my name is Tom Nutter. I'm a psychiatrist, and I've been in the Chicago area for now, I think my wife and I moved here about 28 years ago now.
Yeah.
But I'm new to county. It's about 10 months that I've been in my role, and my role as Chief Behavioral Health Officer has been to stand up our new Office of Behavioral Health, which has really two functions. One's internal to CCH,
yes,
but the second is to really try to impact in as positive a way as possible the entire ecosystem of behavioral health and behavioral health care across Cook County. And so our first big event that you both attended, and thank you for your help, it's an honor to be here with both of you, was the Behavioral Health Summit back in February. And as someone new to this space and putting on an event, and particularly putting it on with pretty tight timelines, we were shocked at the level of appetite for this collaboration and for coming together across not only governmental agencies, but really every type of agency having who is in any way a stakeholder. Mm-hmm. And in 2 weeks, all of a sudden, we're essentially sold out, even though it's free. And more than 700 people came, and there was lots of input. We structured it as a day of structured listening to really kind of get a sense of what the priorities should be, what folks are seeing across the geography of Cook County, mm-hmm. and have been able to carry that momentum thanks to American Rescue Plan Act funds into a big announcement earlier this week in which we were able to award $44 million in grants to agencies across Cook County, particularly in disinvested communities. So we're thrilled about that. That's a great day when you get up and get to feel like you're Oprah for a day. And a little for you, a little some for you, some for you. And just the amazing people that I've been able to meet over the last 10 months has been, I'm just so looking forward to our future work with the two of you and with lots of other partners that we have.
It's an incredible amount you've gotten done in 10 months, and I'm going to ask you more about it. I first want to ask you, Chief, so Dr. Nutter's taking that county view,
sure,
and is the board president's lead on behavioral health. You're the governor's lead on behavioral health.
Yeah.
And so can you talk a little bit about, what led you to this moment? You came back to Chicago from Philadelphia. Mm-hmm. Right. And you've been in your chair for a few years. Can you talk a little bit about the shape of your role?
Sure. So, and again, as you said, Deputy Commissioner, I'm David T. Jones, Chief Behavioral Health Officer for the state of Illinois. And my role has really been about aligning, coordinating, and integrating the broader kind of behavioral health system. And certainly that work has been underway for some time, but I think with the governor's insight, it was, I think we can do an even more pointed job of kind of bringing the, if you will, the broader system together so that we are looking at both the chronic diseases of mental illness and substance use disorder, and making sure that the treatment system and the ecosystem is really approaching those in a more integrated way. And so I've been doing that work with, again, as you both know, with the Cook County and certainly Chicago. You guys have been phenomenal partners, along with the trade associations.
Yes.
I think that Illinois is really fortunate to have a really vast behavioral health provider network, and they have just been great in terms of kind of adapting to kind of the new models of care that are emerging. And then the work with people with lived experience. Certainly we have also been really intentional in partnering across and throughout the state with people with lived experience. And so it really is that kind of conglomerate of folk coming together, working to say, how can we have, if you will, not only the most effective behavioral health system in the country, we really are, shooting big to want to have the best behavioral health system in the world.
Yes. In both of your roles, I mean, and it's in my role too, a lot of what we're doing is trying to integrate and improve communication with systems, within systems that don't always integrate as well as they should. Dr. Nutter, you talked about, you convened this group of providers around the city I think it was about 4 months ago. There's a lot of recognition that we're in this moment of behavioral health. People use the word crisis, but there's this great focus on it, and I felt that energy in the room. You had 700 people there, as you mentioned.
Yes.
You're doing this strategic planning process, and then you quickly turned around and were able to put a lot of money out into the community, which I think for folks maybe not working in government, appreciating how difficult it is to do that, and as quickly as you did it.
We have an amazing team and a lot of support from our leadership. So yes, thank you. Well, it's not easy, but it's a whole lot easier when you have the right people.
Can you talk about, the announcement you made last week? What are the shape of the awards you're making? Can you talk a little bit about that investment?
So we had, again, really the theme over the 10 months I've been in this role has been so many folks from across all stakeholders being willing to help. I was just thinking as Chief Jones was talking, I think I'm still waiting for anyone to tell me no when I ask for help on anything. And thank you both for all your yeses over the last few months. We were anticipating getting a fair amount of interest.
Yes.
And one of the folks on our team who'd been a little bit more familiar with behavioral health processes, et cetera, behavioral health and public health, had said, I think we're going to get over 300 applications. And it turns out we had 324. Requests totaling close to 300 million. So even though we had 44, you just see the amount of the vastness of the need. There's this paradox, as we've all talked about, in that we're in a moment of crisis, but we're also in a moment of historic alignment and historic interest and historic political and public pressure to come together and to craft better solutions. And so to go back to what you originally asked.
Yeah.
So of the awards, over half are going into youth prevention, positive youth development, youth services. About 10% are going into crisis care, and the rest into adult care and recovery, some into adult prevention. But we're particularly proud that the investments are going largely to communities that have had decades and decades of disinvestment, and really that the awards have been spread throughout Cook County, and we're just meeting some of our new partners folks that I hadn't met before on Monday. It's just such a thrill to be able to know that we're not only going to be able to help fund these folks, but to come alongside, learn from them, collaborate with one another, take what we've learned and in our conversations and in others to bolster the entire system. So.
And the total investment was 44.
The total investment was $44 million over about 2.5 years.
The next 2.5 years. So $44 million going into largely community behavioral health organizations in Chicago, Cook.
Yes. Yeah, all in Cook.
And so that includes outpatient, that includes crisis care, that includes higher levels of care.
Yes.
With crisis care, this is something that cuts across all of our work, that we know that we have a problem in the United States where many, many people who experience behavioral health crisis end up in systems that are not well suited to address the crises that they experience. It's 911 calls, it's going to emergency departments, it's inappropriately ending up in inpatient settings, it's God forbid ending up in the criminal justice system.
Settings, yeah, sure.
And so, Chief Jones, I know one of the biggest items that was on your plate, Dr. Nutter and I, fund and operate programs in crisis, was to help implement this national strategy around crisis care. Can you talk about what's new about this approach to crisis care? And can you tell our audience a little bit about what are the core components of that strategy and how are you thinking about it as you're implementing it?
Yeah, it's Deputy Commissioner, it's a great question in that part of the strategy, what, as was previously mentioned, that we really recognize more and more is that, both, again, the chronic nature of the diseases of mental illness and substance use disorder really require that response in addition to addressing the acute episode that sometimes certainly occurs kind of during crisis. And so what we've recognized, and again, you guys have been and will continue to be great partners in this, is that, as the feds have really rolled out those three components of the crisis system, a place to call, that's the 988, someone to respond, the mobile crisis response, and then a place to go, whether those be crisis stabilization units, behavioral health urgent care centers, the living room models, or certified community behavioral health clinics, that the work in terms of kind of being sure that we are thinking about not only how we have a really effective response to help folks stabilize during their crisis, but then to also, again, recognize that we have to do the work of following up beyond the crisis. And that, part of the challenge has for a long time been that the investment in terms of, for example, in 988, which is a really, I think, wonderful investment, that the connections beyond the crisis system so that when people are experiencing challenges around, their health-related social needs, challenges around kind of housing, challenges around employment, other challenges, that whole, the connectivity across that system is really important. And so that's, I think, as the state, what we're focusing more and more on, again, is saying we want to develop what we're referring to even as a unified crisis continuum, where we're working very closely with kind of all of the counties, and Cook County in particular, and the city, to then have that unified system that really is able to respond. Last thing I'll say, too, is that, we are recognizing that as individuals kind of experiences the challenges that they sometimes experience, that, it really is about, because the disease is so chronic, that when somebody may return to use with substance use disorder or symptoms reemerge, that's actually not at all a failure on their part. It really is more of the system needing to accommodate that and be, again, more chronic in terms of how it addresses those needs. And so that's where I think we're focusing. And again, I think that's where we have great opportunity for partnership down the road.
And at the local level, part of what we have to do is we see the strategy, the federal strategy around those three parts: a place to call, a team to go, a place to a person to be taken, and we have to figure out how to implement it. And Dr. Nutter, you're a psychiatrist by training. I'm sure you've worked in emergency departments and you've seen the way we've historically done this. So I'm wondering, as a psychiatrist and now in your new role, as you hear Chief Jones talk about that three-part strategy, how are you seeing your role play out in that, and how you're approaching reimagining crisis care in Cook County?
I think as was pointed out, I think the federal kind of paradigm of someone to call, someone to respond, someplace to go really does kind of crystallize well the issues that we face. And I think now that 988 has been, I think we're about 2 years now on 988.
Right. Yeah, 2 years.
I think that has that at a local and national level is working well, but it's in some ways it's the easiest part. It's all hard, but that's the least difficult of the three. And the next level, of course, is coordinating who's going to respond where, how things go in one neighborhood may be very different than another, how calls are routed in terms of whether police are involved or not. These are complicated questions. These are complicated questions, and I think there's opportunity for greater greater coordination and collaboration, not because people are trying to do things at odds with one
No,
another,
this
but because
is a heavy lift.
But because it's a heavy lift and everyone is busy and has a lot on their plate. So I think the challenge for us over the next couple of years, I think, is to take that to the next level, and then the somewhere to go is I think we could all say the least well developed at this point of the three. We still have far too many people going to emergency rooms, which are, to your point, can be if you're feeling. I think a lot of people don't appreciate being psychotic is a very frightening experience for people.
Yes.
And if you're in the middle of one of the most frightening things that's ever happened to you, the chaos of an emergency room, especially a busy urban emergency room, it's needless to say, it's not helpful.
It's about the least optimal
It's the
environment.
least optimal.
Yeah.
It's the least optimal. Now, it is necessary in an awful lot of cases,
Yeah.
but it's the least optimal. And so I think we have a lot of opportunity to be able to provide different settings, figure out, as Chief Jones was referring to, where the living rooms are going to be, what the CSU models are going to look like, what the reimbursement structures are going to be, how those are coordinated across neighborhoods, et cetera. And I think that as we're a couple principles that I think we all agree on, there has to be enough uniformity that people know what to expect across the city, across the county, across the state. But there's also a lot of variation.
Yes.
What that looks like in Englewood may be different than Ravenswood, which may be different than downtown, which may be different than the western suburbs or the Southland, or certainly where I'm from in downstate Illinois. It could be is a very different thing. I think the other thing, to Chief Jones' point earlier about what's upstream of the crisis care continuum, is that given that we have a major deficit in terms of just the overall number of providers with respect to the need, with the number of providers going up year by year, but the needs going up much faster.
Yes.
We have to, I think, also be aware at the same time, while we need to bolster our crisis systems, we have to be aware that each one of those folks that go into those systems is someone who's not serving in another role that might actually prevent folks from falling into and needing the crisis care continuum to begin with. And so there's a lot of that's a lot. I've kind of been all over the map there, but that's because these are complicated problems, and this is again part of what we.
We're talking about
yeah.
building new systems, right?
Yeah.
We talked about 988. So for our audience, 988 is the new federal, it's the 3-digit crisis line
Yes.
that was implemented in July of 2022 that anybody in the United States can call if you're in crisis. And at the local level, we oversee 911 systems, which has historically been where a lot of these calls had gone,
Yes.
right? So one of the things the mayor has given us a charge on, Mayor Johnson, has been integrating these teams into our 911 system. We had a pilot for the last 2 years. We're substantially expanding it so that when residents do call 911, if these teams are available, they will be met by behavioral health professionals rather than
Yes.
the historical response, which has primarily been policing. But I think
Which is a lot to ask of police.
It is. We ask police to do
Yes.
meet every myriad emergency. But I think one of the things we're working on the local side is how do we actually identify calls that come into 911 that might be better for 988,
Yeah.
right? And that speaks to this need as we're transitioning into these new systems to be able to redirect things that come into the old system out to this new one. And I think, Chief, we saw, already substantially improved rates of people calling 988, right? You've seen those numbers go way up.
Yeah, yeah. And I think, and to both the points that you're making in particular, so I think, as we continue to get better at this, we are, through, for example, the mobile crisis providers and co-responders having a healthcare response to a healthcare need, as opposed to a police response to a healthcare need.
Night and day different.
Right, exactly.
Night and day
And certainly we know that law enforcement are doing the best they can do. Again, I think that the training in terms of having a mental health professional, a clinician, a person with lived experience who then has that additional training to be the people who are responding to someone that's experiencing, again, whether it be a psychiatric crisis or a crisis related to a substance use disorder, is not only a far better response, but it also then results likely in a better health outcome for that individual and system. And so, I think that we really, I think, are excited about that. And again, I think that we also are looking at the kind of emerging, as you were just talking about, Matt, the emerging kind of models, and we think about, as we talk about that, when you're saying, and kind of the probably least evolved around a place to go, the certified community behavioral health clinics, right?
Certified community behavioral health clinics,
right.
CCBHC,
right? And to me, what's so important about CCBHCs, and again, as you all know, they really are developed to address kind of the behavioral health needs for people who are experiencing both challenges around mental illness and substance use disorder. But I would think what really, to me, makes them even more distinctive is that for those folks who have more moderate or higher acuity in terms of severity in their mental illness or substance use disorder, or both, that's really what they're uniquely positioned to be able to address. And then they also address kind of the primary care issue. And as we all know, it's not uncommon for somebody to maybe have a diagnosis of schizophrenia, alcohol use disorder, diabetes, and need to have the whole thing addressed. And so that's part of what CCBHCs, and the beauty is that whether you have public health insurance or you have commercial insurance, or for that matter, you have no insurance at all, if you present to a CCBHC, they are required to treat you. And then, we can certainly talk more about the prospective payment system model. So the financing model that's part of that model of care, which I don't think we've ever seen in this behavioral health space.
I mean, one thing that's interesting to hear you talk about the CCBHC, Certified Community Behavioral Health Clinic, is it sounds like we're building a system that mirrors the types of illnesses that, or it meeting the needs of people as they actually experience them, right? That mental health and substance use conditions often are interconnected. People often have both.
And if your clinic is structured to meet one or two of those three types of needs that Chief Jones was talking about, you're not only failing to meet the other need, you're really hampering your ability to meet what you say you're even there for.
That's right.
If you don't manage the whole person, you're going to not even be able to manage that small part of the person you tried to carve out for just the treatment of their mental illness, just the treatment of their substance use, just the treatment of their diabetes, et cetera.
That we know that
connected.
People living with serious mental illness die on average 20 years earlier. It's because of untreated chronic disease. We know that mental health and substance use conditions frequently co-occur more than they are separate. And yet we've had this system that was not designed to address all the needs at once. And so Chief Jones, the state had a desire to try to start expanding this CCBHC model. So you got an exciting announcement. Can you talk a little bit about what you did and what was the good news?
I really have to give great kudos to Healthcare and Family Services with in terms of who is the oversees Medicaid for the state. They were the primary kind of conduit in terms of submitting what we were able to be awarded these applications to the Federal Substance Abuse Mental Health Services Administration, and then connected to Centers for Medicare and Medicaid Services, where Illinois was awarded a demonstration grant, meaning that we have been approved to expand this Certified Community Behavioral Health Clinic model of care. And again, HFS and within the Department of Human Services divisions of mental health and substance use prevention recovery, Office of Medicaid Innovation, who's also kind of sits with part of the university, they all came together And I mean, did just a phenomenal job of submitting, again, an application that spoke to kind of the integration that not only was happening across kind of all of those large departments, but that we were going to be reaching in and working with the counties, that we were going to be working, with the city, the third largest city in the country. Phenomenal leadership, and you, Deputy Commissioner, and you, and we really appreciate that. So, when we received this award, we were really ecstatic because there have been, again, a number of I believe at the time there were 20 behavioral health providers that were operating 26 clinics. And so now those numbers have expanded. There's probably something like 25 that then will be operating 35 clinics. It expands the number of community-based programs that will happen across the state. And then with this one, though, in particular, as I said, so what we're most excited about is that the prospective payment system, which essentially will reimburse for the cost of providing care, which again rarely ever happens, we now have a sustainability process through this demonstration grant to sustain that model of care going forward.
So it's not just changes in developing this new type of care entity, it's also how we're paying for it.
Exactly right. Exactly right.
And it sounds like what you're saying with the change in how we're paying for it is it's based on the actual cost of care, rather than us trying to sort of make the finances work when actually the costs we're incurring don't match what we're getting paid to do it.
That's exactly right. And if you think about it, and you guys, you know this better than I around, so if you look at historically, the reimbursement on the physical health side for medical and surgical rates has been pretty high, right? Very high. And so for behavioral health rates, though, candidly, sometimes they maybe cover 3/4 of the cost, sometimes not even that.
Particularly for those that are underinsured.
Exactly, right.
It's very different who you're.
That's right.
Yeah, and so now with the prospective payment system rate that's part of certified community behavioral health clinics, if whatever 100% of the expense, the reimbursement will cover 100% of the expense. Again, very rare.
It's hard to, I think, overstate what a big deal this is. I mean,
it seems like an unexciting detail,
but for
and
those
the
of us
model
who
itself
do this work,
is not necessarily the most surprising thing, but this is night and day.
Yes,
this is in a lot of cases life and death.
I mean, I was thinking about a family that I was talking to last week where their child, adult child, has a psychotic disorder, right? And how overwhelming it can be, right? And not knowing where to go. Who do I talk to? What number do I call? And finding
especially early in the illness.
Early in the illness where psychosis can be very frightening, not only for the person and family, but even the healthcare system. Very few providers, as we know, actually feel comfortable managing and skillfully responding to psychosis. And so we're talking about a system where CCBHCs, no matter where you live in Illinois, as we build out the system, the idea would be you have a place in the community where you can just kind of show up and we will help you figure out what needs to happen. You don't need to know who to call. You don't need to have to cobble together different providers working across different systems, right?
That's exactly right, Matt. And the challenge really has been, to the point is, again, so you want to have, we've seen certified community behavioral clinics be effective, but we haven't seen them be scaled. So that if you're talking about, can you access in Southern Illinois? Can you access in the far northern parts of the state? Can you access in the central part of the states? Eventually, we will have CCBHCs. We have some now, but we'll have them throughout the state. In fact, I believe there are, when we think about between kind of Cook County and the city right now, I think there probably are anywhere 4 to 6 or so that have relatively recently come on board, which again is just going to be immensely helpful for access, and particularly access for those people, as you just described, Matt, those people who may have a high acuity, a diagnosis of schizophrenia, a diagnosis of psychosis, along with opioid use disorder or something like that, or cardiovascular disease. And to your point, doctor, just being able to treat the entire person, the whole person, it marks a new day in behavioral health.
Well, and I mean, at the local level, 2 weeks ago, you all know, Mayor Johnson stood in front of the Roseland Health Center and announced that we were reopening that mental health clinic, and we're reopening another clinic in the Pilsen neighborhood as part of the mayor's mental health expansion strategy. And in the report that we released, we talk about the CCBHC model. Yeah. And I think that's part of the power of setting a strategy is like Dr. Nutter, you and I, and local people around the country are seeing that strategy. And then as we're advising mayors and board presidents, we then need to think about how does that strategy fit into our planning. So we don't want to just open a mental health clinic where all we do is mental health. We want to think about how are we going to fold in substance use care? Right. How are we going to address basic primary care needs? And I know on the city side, that's one of the things I'm most excited about as we reopen this clinic in Roseland is thinking about how are we going to do that over the long run. I mean, Dr. Nutter, you put $44 million into this community behavioral health system.
Not personally, to be clear.
Not out of your back pocket. But some of it is ARPA funds. And this is a question that we're getting a lot, right? We've invested a lot of ARPA funding, so that's American Recovery Plan Act funding that was one-time funds that local communities got. How are you both thinking about, us taking advantage of this opportunity to spend these monies and invest in the community while also planning for those funds running out? I realize that's a big question, but I'm curious how you're thinking about it, and then Chief Jones at the state level, how you would advise local people to think about that.
Sure. Yeah, I think we're considering ourselves, stewards of an immense resource.
Yes.
And certainly don't want to pour that resource into something that's not going to be sustainable, that we're not going to be able to figure out a plan for come December 2026, and that's a challenging thing, and the solutions I think are going to be largely. I don't think it's easy to speak in broad strokes about that. I think that those are things that are worked out well at the individual program, individual agency level. It is a big challenge, I think, facing all of us, but it's also, of course, a huge opportunity because this is an infusion of funds that we haven't seen before, and so it's an opportunity to make these investments in programs that we certainly hope can be and will be working toward having become sustainable.
Yes. I mean, how would you advise, in your role as you're thinking about that federal strategy and implementing it at the state level, what would you say to people like Dr. Nutter and myself? We're trying to get some free advice here, Chief Jones, about how we should be thinking about that.
Well, you're always happy to help great friends. Right?
We're always happy to hear your advice.
Right. And I would say that the shift really that we're seeing is around more to value-based payment structures, right? And so we know that.
And can you explain what that is?
Yeah. So the idea of historically what we've done is we've used kind of a fee-for-service structure. So you get a procedure and you get reimbursed. You get a procedure, you get reimbursed, as opposed to saying, so what's the kind of total treatment that you need in order to have your best health outcome? And so let's pay for the value in that. So let's show that shift. And I think again
of the outcome,
right?
not the procedure,
right? Yeah. Because the procedure, while it may help, it also may not, but there's been a reimbursement where, again, with value-based, it really is around, does, Dr. Nutter and does Deputy Commissioner Richards, as a result of having received this integrated treatment, as not only is your health outcome better, but your quality of life is better. And so it's really about kind of the structure of paying for those outcomes.
Paying for outcomes, not paying for services.
Exactly right. Exactly right. And so again, as we just talked about, probably at the wrap, I know we're probably getting short on time, is the Certified Community Behavioral Health Clinics as a great example. Again, that prospective payment system is moving us very much in that direction, where again, it's about integrated care, it's about integrated treatment, it's about having better health outcomes, and then again, paying for all of that at the expense that you need to in order to then again be able to achieve those good health.
And as we're funding people at the local level, and we're operating our own programs as we are in the city and you are in the county, is how do we maximize these new reimbursement opportunities as we're doing our financial planning? How do we braid other funding sources? Braiding is a word we're hearing. Identifying different funding streams that we have, braiding them together to get the outcomes that we want, not over relying on any single stream. And that's going to require the type of partnership that we're trying to describe today. As you look forward,
And I can even, to that point, and again, it's an excellent point around the braiding, because, so we have the opioid settlement funds that
that's a good example.
Right,
yes,
as a result, that has come in as a result of, the kind of the historic abuse that some of the pharmaceutical companies did with really pushing opioids and the consequences of that. And so you have the opioid settlement funds. You actually also have cannabis tax revenue funds. And then, again, we start to see these models of care where we have, again, the CCBHC perspective rates. And so it is really about, so how is it that we braid those kind of with kind of historic grants, and still, there's still some fee for service, so that, again, at the end of the day, we really are getting the greatest value from the treatment and then the greatest health outcomes.
That's great. As we move forward and we close out here, I'm thinking about, the power of partnership across levels of government with our partners in the community. As you think about the next 3 years, what are you most excited about seeing unfold in the county, in the state? What's the thing that's most exciting and galvanizing for you as we're moving into this moment?
Yeah. So I think if I just to
please.
So I think, as we just talked about, I think we're seeing a financing structure that will actually support better health outcomes. So I'm really excited about that. I'm also excited about the real concerted way that integration is occurring. For too long, it's really been around the silos of kind of mental health, substance use disorder, and then even not being as explicit in connecting with the social determinants of health. And so I think I'm excited about that. And then something that we haven't had enough time to touch about is really also more of the upstream harm reduction kind of work that also is is still being kind of coordinated. So those are kind of the three pieces that I think we at the state are really looking forward to.
That's exciting. What would you say, Dr. Nutter?
Well, as you were talking about braiding services together and how we as systems are learning this new landscape and how to make the economics work in ways that they couldn't work before, so that we can provide services in ways that we were never able to provide them before. The thing I'm most excited about in my job in particular is the countywide strategic plan that we're going to be hopefully rolling out after a lot of input from a lot of folks, including the two of you, later on this year, likely around December. And the reason I'm so excited about that is that I think, given this moment that we all have, it would be easy for another kind of haves and have-nots kinds of scenarios as people learn, certain agencies learn how to operate more quickly than others. And by having a comprehensive plan, we not only, I think, can have exercise optimal stewardship of the resources we have, but also really make sure that we're disseminating information, coordinating care, addressing gaps, avoiding redundancies, that sort of thing, in a way that's not just occurring in one place over here and another place over there, but can really be done for us across the county.
That's right. And I think, as a public health person, I'll answer my own question if I'm allowed to do that too. I think you both said it well. I think, I'm a social worker. I'm also interested in this prevention conversation, right? That, how do we think about promoting mental health at the population level, how it's connected to people's sense of safety, income security, employment. The mayor announced on Monday, we're making a corridor investment in the Austin Health Hub. We're investing in the actual infrastructure of communities and public schools and housing. That feels like, I think, sometimes to people a long game, a middle to long term sort of investment, and it is, but it seems critical.
That's the best use of those dollars. If you're thinking long term, in a lot of cases,
I think so. Yeah. So while we're building this treatment system that we've long needed, I think it's also thinking about how do we promote conditions of wellness in the neighborhoods and places where people live, so that folks, to the extent that it can be prevented, don't have to interface with that system at all. And I think that's why we're here. But I want to thank
Yes.
both of you for your partnership, for your expertise. Public service is just that. I think it's service, and I know both of you have many other opportunities, but I'm grateful to have such great colleagues and people that are doing this work together and available to talk and give advice. So thanks to both of you for your service to our communities.
And we thank you, sir. I mean, for being, again, a phenomenal partner. And Dr. Nutter, I really have appreciate both as I've gotten to know you guys, and the partnership continues to grow. Again, it keeps me, as they say, it gives me additional hope.
Well, thank you.
Well said.
And I hope
Very much
for our
agree.
audience that this conversation has helped enlarge your understanding of some of the things that we're working on, how we're the plans that we have, how we plan on financing this system that we're building out, and look forward to you joining us back on our next podcast as we address additional topics about the health and well-being of Chicago residents. So thank you.
And that's our show. Thanks for joining us today. Don't forget to rate and subscribe wherever you find podcasts. I'm Dr. Bora, and we'll see you next time.